So, hello, everybody. So before we do get started here, I just do want to let everyone on the call here know that we are audio recording this presentation so that those who are, unable to come today can tune in later. And that this audio recording will be posted on the Capacity Research Unit to listen to later on. So hello, and my name is Shaheen Qasim, and I'm a postdoctoral research fellow at the UBC School of Nursing Capacity Research Unit. I'm stepping in for a little bit here for Vicky Bungie, who's the director of Capacity Research, who will be joining us in a little bit. But before we move on to this exciting hour ahead of today's seminar, which I believe is the first of 2024, I'd like to just invite you all who's here today to just introduce yourself in the chat if you'd like, and acknowledge the lands upon which you are situated on or you're coming from. And I'd like to actually acknowledge the lands upon which the Capacity Research Center is situated upon, which are this ancestral and unceded territories of the Musqueam and Hunkaminam speaking people. And I'll just share a interesting fact that the Musqueam people are matriarchal, which means that the women of the Musqueam people have long been part of the leadership of their communities for thousands of years. And throughout time, women have been the weavers and the keepers of knowledge, and are essentially viewed as sacred life givers and healers, and among the community's fiercest protectors. So with that in mind, let's move forward into this super interesting hour with Michelle Gagnon. Michelle is a PhD candidate out of the UBC School of Nursing, and will be sharing her extremely important work on just the current understandings and the practices related to psychedelic assisted therapies. So thank you so much, Michelle, for your time today. And for being with us today and sharing your work. And I'll just hand it right over to you to tell us a bit more about you and your work. And then we'll all just get an opportunity to have some conversation and maybe some questions around your presentation as well.
Great, thanks so much for the intro. Thanks everyone for being here. I love this topic. I'm so excited to talk about it. I just want to give you a caveat that my co-presenter, my cat, is with me. She may walk across screen. She's meant to be here. So I'm just gonna share my PowerPoint here. Okay, can everyone see this slide? Great, okay. So again, thank you for being here. This presentation was part of my candidacy exam that I went through just a couple months ago with Vicky. And I want to give you a little bit of a caveat at the beginning. This is going to be a bit of a general overview of psychedelic assisted therapy, where we're at right now. It's by no means comprehensive, but I'm looking to have a good discussion at the end. A few other things throughout, I'm going to use the acronym PAT instead of psychedelic assisted therapy, just because it's shorter. And I'm going to be talking about some tough subjects, including end-of-life distress, cancer, depression. So if this ends up being too much for you, it's not personal to me, you can hop off, no problem. I also designed the slides to be pretty image forward. So if you zone out, there's something nice to look at. So I also just want to start off by saying I spend most of my physical and mental time in two places, and I want to acknowledge this with my own land acknowledgement. So firstly, I live in Calgary. This is located in the heart of Southern Alberta, and I acknowledge and pay tribute to the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, the Tsuut'ina First Nation, and the Stoney Nakoda. It's also home to the Métis Nation of Alberta, regions 5 and 7. And while I'm not physically in BC, most of my mental space is in Vancouver at UBC with my PhD. And this is located on the unceded territory of the Coast Salish peoples, including the territory of the Musqueam, Squamish, and Tsleil-Waututh nations. So for our presentation today, we're going to have three overarching sections. We're going to talk about psychedelics. So what are they about? Kind of what's the landscape and a bit of the history. We're going to move into psychedelic assisted therapy and the essential elements of what this is. So this includes the phases and key components. And then we're going to tie it off with implications for healthcare. So this is going to look at where we are right now and where we're going to look to the future. So starting off, the term psychedelic, what are we talking about when we talk about that? So this was termed in 1957 by psychiatrist Dr. Osmond while he was working in Weyburn, Saskatchewan, which is kind of cool. And it's derived from the word psyche, meaning mind, and delic from the Greek delos, which means to bring to light. And this is to capture its mind manifesting properties. So psychedelics encompasses a group of plant-based and synthetic chemicals that induce a specific altered states of consciousness, which is marked by sensory, perceptual, and thought changes. So psychedelics are generally categorized into what we consider classics or the classical psychedelics. So classics include psilocybin, which is the active component in magic mushrooms. There's DMT, which is a component in ayahuasca, and then there's LSD. So these classics, are all substances that activate the serotonin 2A receptors in the brain. There are a number of psychedelics out there, and I'm not going to cover all of them, but I am going to talk about two other atypical psychedelics. And they are considered atypical just because they don't touch on or activate that same serotonin receptor. So the first one is MDMA, and this occasions empathy and emotional openness from serotonin release in the brain. And the second one we're going to talk about today is ketamine, which also occasions this altered state of consciousness at sub-anesthetic doses. So for any folks who work in healthcare, we might know that we use ketamine already for things like conscious sedations or for addressing pain. When we talk about ketamine in a psychedelic use, it is at this sub-anesthetic, more dissociative level. So it kind of still brings people into that non-ordinary state. So this being said, the mechanism of action or why psychedelics work the way they do is really not well understood yet. But there's a thought that they can be related to neurobiological and psychological mechanisms of action. So when I say neurobiological, it's thought that this is related to connectivity or neuroplasticity, where new connections are being developed and rewired in the brain. Whereas psychological mechanisms are more related to emotional breakthroughs, insights, and changes or flexibility in one's view of the world. So while the mechanisms of actions are poorly understood, we know that they produce these altered states or non-ordinary states of consciousness. So when we talk about the peak psychedelic experience, I'm going to be talking about that a lot today. The peak experience just means that point in time where the medication, the substance, the psychedelic is at its greatest effect. So the psychedelic experiences are characterized by profound and transformative psychological experience that's marked by a departure and significant deviation from the known, the familiar, and ordinary waking consciousness into a new, more ineffable territory. And ineffable means difficult to describe. So that's some of the trouble we get into when we're trying to explain what this feels like. It is ineffable. So it's thought that the peak psychedelic experience, that peak psychedelic state, increases flexibility, sensitivity to the environment, and openness to change, with profound alterations in perceptions, with a sense of meaningfulness, insightfulness, and unity. And in fact, studies using psilocybin assisted therapy for conditions like smoking cessation and existential distress, in these studies, it was found that participants overwhelmingly rated their psilocybin experience among the most personally meaningful and spiritually significant experiences of their lives. Okay, so going into a little bit of a history here, psychedelics are among the oldest psychoactive substances known to be used by humans, and they've been used in healing traditions for millennia, beginning with historic indigenous shamanism. So originally introduced by indigenous cultures around the world, the healing properties of plant medicines elicited the interest of Western researchers in the 1940s. So helped along by the synthesization and discovery of LSD by biochemist Albert Hofmann in 1943, psychedelics became widely used among researchers and clinicians until the 1970s. So there was really kind of this early research era, what some consider the golden era of research between the 40s and 50s until the 70s. And so the work of early studies laid critical groundwork for the more recent research, including the impact of non-drug factors on one's experience. And we'll be getting into non-drug factors in a few minutes. So during this early era, this time, more than 1,000 articles were published with about 40,000 patient sessions, a number of books, and 6 international conferences. However, psychedelics did not perform well in randomized controlled trials, and critiques and restrictions mounted through the late 60s, where psychedelics became synonymous with counterculture activities, quote unquote bad trips, and drug abuse. And after becoming a controlled substance in 1970s, the psychedelic research was effectively halted. So while psychedelic therapy continued to be conducted in underground networks, a renewed interest in their therapeutic use started in the 2000s. So there was a number of decades where there was no research being done. And this shift was kind of helped by changes in political attitudes towards clinical research, the advent of new technologies. For example, now we're seeing studies being done with MRI machines and EEGs to look and map at the brain. There was also a bunch of retrospective psychedelic studies done and a ton of advocacy on the part of researchers, clinicians, and the community. And so now research into the psychopharmacological effects of safety and efficacy has increased exponentially since the early 2000s. And in 2020, Health Canada granted landmark legal psilocybin exemptions for individuals with end-of-life distress, making psilocybin legally accessible outside of clinical trials for the first time since 1974. So now psychedelics above ground are accessible through 3 pathways, and they are all associated with the federal government. Right now, only psilocybin and MDMA are accessible. And here are the 3 pathways. I'm going to go over them very briefly, but we can talk about them more later. So the first one, the preferred route that the government would like us to go through to access psychedelics is through clinical trials. This is very healthcare provider and research driven. Clinical trials are great. They have a ton of benefit. However, there is a lot of barriers towards accessibility, and there's a lot of barriers towards cost as well. The second route of access is through the Special Access Program. And that's right now how most folks are getting access to psychedelics who are in the community. So this is very provider forward. So a provider will write down an application for an exemption on behalf and in tandem with the patient. After doing some assessments, they'll make a case to Health Canada, and Health Canada will come back with a decision of yes or no. And then the third way is through a Section 56 exemption. And it was through these Section 56 exemptions that these early 2020 exemptions were given. The Section 56s are very patient forward. So the patient has to write out an application. They can be quite cumbersome and long, and that gets sent to the Health Minister of Canada, and Health Minister decides whether or not to approve or decline that exemption. Again, the preferred route from health, the government, is clinical trials. And then in community, we're using the SAP, and Section 56 they're not used as often anymore. With the SAP, the turnaround time is usually a couple of days to hear back from Health Canada. But with the Section 56 exemptions, we've been seeing that folks can be waiting over 500 days to hear back, which is quite lengthy, especially for folks who are at the end of life. So to understand the interest in psychedelic assisted therapy, I'm going to go over two really key points. So the first is that contemporary studies support the notion that psychedelic therapies show promise in treating conditions that share a key feature. It's this narrowed, internalized mental state marked by self-critical, ruminating processes and rigid focus. And that's why it's thought that psychedelics can treat a range of conditions from affective disorders to addictions. So just to give you kind of a snapshot of where we are with clinical trials, again, the preferred route of research for Health Canada, I want to show you this table. This was taken out of my candidacy proposal. So this search was done at late October. And I just want to compare kind of the number of trials. So as we can see, psilocybin at the time had 122 proposed clinical trials, ranging from pre-trial submission all the way to completion. They had 32 completed. And then at the second from the bottom, there's MDMA, 59 proposed and 39 completed. Since then, things have changed. But to give you an idea that when we're seeing what is being accessible in Canada, it's very much based on research of clinical trials. And then the second key point that I want to talk to you about why there's interest in psychedelic therapy, is the quality and intensity of the peak experience is predictive of clinical outcomes. And the therapeutic effects are experience dependent, which means that the therapeutic effects are not simply the action of the drug itself, but it's about how one has their experience with the medicine. So it's actually thought that the quality of the peak experience might be the critical determinant in the therapeutic success. So when we're talking about therapeutic success and therapeutic effects, these are things like reduction in depression symptoms. So it's not just necessarily taking the psilocybin or the psychedelic that will determine how symptoms will reduce, but it's actually one's experience in it. So as I mentioned earlier, early research strongly suggests that non-drug factors are as influential to the content and character of one's peak experience as the dose of the medicine itself, which is quite unique. So just to give you an idea of some potential non-drug influencing factors that have been investigated and that have been thought to be important from earlier research. These factors include one's capacity for acceptance, surrender, and trust going into the psychedelic experience, one's emotional breakthrough or catharsis, and the reliving of trauma and defining life events while in the experience and afterwards, insights about the self and relationships, one's relationship to the music being heard during the psychedelic experience, one's success at letting go, and the degree of quote unquote closure attained post-session, which we will touch on soon, and one's priming or suggestibility and the quality of the relationship between the individual undergoing PAT and the therapist guiding them through. So the importance of the relational component cannot be understated. So taken together, much of the research indicates that an isolated experience with a psychedelic does not inherently make for therapeutic benefits. Rather, enduring outcomes are contingent on contextual factors. like the presence of skilled therapists or guides that help facilitate the overall PAT process. And so this is going to lead us into what are the steps of psychedelic assisted therapy and associated components. So in this next section, we're going to talk about these phases and these components of set and setting, which are considered essential elements to PAT. And PAT is thought to, again, harness the peak psychedelic experience as a therapeutic window to facilitate insight and release emotion towards a healthy revision and outlook of lifestyle. So having a therapist or provider present is widely considered essential to ensure patient safety and maximize therapeutic benefits, and to help folks move through the phases of treatment while attending to the overarching context of set and setting. And a little history fun fact, Susie Ramstein, she was the 21-year-old lab assistant to Albert Hofmann in 1943, who synthesized and discovered the properties of LSD. She is widely considered the first ever LSD guide because she was asked to pedal beside Hofmann during his infamous bicycle ride and stayed with him at his home during the most intense part of his LSD trip. So as a scientist, he discovered the psychedelic properties of LSD by actually trialing it himself and then cycling home afterwards to go through that. And Susie Ramstein was there with him the whole time. So to go through the phases of PAT, there's effectively three. There's the preparation phase, the medicine day itself, and integration. So despite having a commonality of sharing these three phases, there's a diversity in models that have been developed by academic, corporate, and nonprofit groups to support their research and treatment goals. So we'll talk about that in a few minutes, but I just wanted to let you know that this is generally the overarching approach. So when we're talking about what goes into preparation, a major aim of the preparation sessions are to establish trust between the person who's undergoing the psychedelic experience and the person who's going to be supporting them. And this is often folks who are therapists or providers. So these preparation sessions also include reviewing consent and health history, inclusion-exclusion criteria, and setting intentions and expectations for that medicine day. So proposed guidelines emphasize that trust and a positive therapeutic alliance must be established prior to administering high-dose psychedelics on the medicine day. Sometimes extra prep sessions will be scheduled to help kind of bolster that therapeutic alliance. And therapeutic sessions can happen over days to weeks. In my practice, I've typically seen 3 to 6 sessions for preparation. Next is the actual medicine day, and this session involves the actual administration of the psychedelic. And so the physical space where this happens is important, including the decor, furniture, lighting, amount of space, and sound. This often includes nature in some capacity, so having plants or paintings of plants or some kinds of running water like a fountain. These are all those non-drug factors that we're talking about. So treatment rooms can sometimes bear the resemblance of a medical lab or office, especially in kind of the more rigid focused areas, whereas there's a lot of emphasis on trying to make it more of like a living room feel than a clinic feel. And support during the peak experience might vary. So it can go from no support all the way to like very established therapeutic models. So it can go from kind of comfort and reassurance, and then often redirection towards the inner experience. And the length of the session is dependent on the medicine, as the effects of altered states of consciousness can vary. So for example, DMT can last 20 minutes, whereas psilocybin is usually 4 to 8 hours. And then we can see up to 12 hours for MDMA and LSD. So just to give you a kind of gist of what the medicine day looks like, again, this graph was based more so on a psilocybin graph than anything. Regardless though, right at the beginning, there is the ingestion and the going in phase. So this is really where folks are settling in. It tends to be a bit more interesting feeling than upsetting for the patient. But there can be some turbulence where it's often based in fear of losing control. And this can sometimes happen with a bit of agitation, anxiety, nausea, vomiting. The next phase in psilocybin, this would be around hour 2. This is where it deepens into this non-ordinary state of consciousness. And that's where this really sets in. But phase 3 for psilocybin, that 2 to 4 hour mark, is the peak. And that's where the intensity and the quality of the psychedelic, that's really what we're looking for. And that's where a lot of the heavy lifting is done. The patient is encouraged to go inwards. Often there will be music. We'll have folks with eye shades. And it's really to kind of go inwards. And folks can be very deep and not in touch with the reality that you or I might be experiencing at the same time. Sometimes people do have a dual awareness though. And then in this 4 to 6 hour mark, that's where it's kind of the coming down phase. It's the cool down, it's more calm. And this is where we'll see folks have that insightfulness. So they'll kind of come out of the inwards and they'll have moments of clarity. There can be a change in music that's maybe a bit more modern. And sometimes there'll be food involved. So people's favorite meal will be prepared ahead of time. And then it's kind of a really delicious end to the session. And this is in therapy where we might read back notes from the session and have a more cohesive narrative later on in the integration. So the third and final phase is the integration sessions. And during these sessions, the providers will help the patient recognize shifts in perceptions and translate learnings from the experience into lasting life changes. So the overarching aim is to support the patient to fully understand any insights discovered and apply them for their life going forward. And high quality integrative support can require more time for patients to recognize and work away from old attracting states of mind. The integration sessions can occur over days to months, and usually the same therapist or provider who has supported the patient throughout the process will stay the same because they've already established that trust reliance. So another caveat here, while these phases are fairly linear, it's not necessarily so with models or some folks, which would require more than one medicine day. So because PAT is a combination of therapy with psychedelic substance, we're seeing various therapeutic modalities, protocols, and approaches being combined with various psychedelics. So there's a few different models I just want to touch on briefly. Overarchingly, some look from the specific psychedelic lens. So we're asking the question, what can this psychedelic address? And then it includes varying degrees of support. So for example, a study in 2006 by Moreno and colleagues looked at psilocybin for OCD, and it included minimal prep, minimal integration, and they found acute but not sustained improvement. Where a number of researchers, including Griffiths, Ross, and colleagues from 2011 to 2016, looked at anxiety and depression related to life-threatening illness, and it combined psilocybin with a more general existential and supportive therapies, and they found overarching improvements. So there's the one model where we're looking from the psychedelic forward. There's another model where we're looking at the therapy protocol and applying it to a specific psychedelic. So for example, some might be familiar with CBT, cognitive behavioral therapy. And this combined, there was a study in 2014 by Johnson that combined CBT with psilocybin for smoking cessation. And this was a very specific CBT protocol that's called Quit for Life program. And they found together that 80% of the participants were tobacco-free at a 6-month follow-up. Another is the BSEFT, which is the Brief Supportive Expressive Group Therapy model. And so Anderson and colleagues used this in 2020 with psilocybin for AIDS-related demoralization. And using the BSEFT with psilocybin, it included a group dosing and individual dosing, and found decreased demoralization at their 3-month follow-up. With MDMA, we're also seeing cognitive behavioral conjoint therapy, which includes couples participating in the medicine session together. So there was a study done by Monson and colleagues in 2020 that used the CBCT and MDMA and found decreases in PTSD symptoms and improvement in relationship satisfaction. So again, to recap, the one model looks at the psychedelic forward, the other looks at the specific therapy protocol forward, and then the third one are theoretical. These are theoretical models, and it's looking at transdiagnostic models, which are models that apply across substances and across concerns or diagnoses. This last group is very early days. It's still theoretical, and they're proposing it for clinical trials. So that's just kind of a little bit of a gist where we are right now with these phases and what we're seeing with some of the models. To finish up this section on PAT, we must discuss the key components of set and setting. So the roots of set and setting date back as far as psychedelics themselves and were considered to be integral elements that could often be augmented through techniques such as singing or drumming, whistling, or smoke blowing. Today, set and setting largely refers to the context within which PAT occurs. So the term set refers to the mindset of the patient and the experiences they bring with them as they enter treatment, including their own expectations, motivations, intentions regarding the session. So this can include the agreed upon goals, programming, models, and techniques for guidance between the patient and therapist during the experience. And then setting refers to the physical and interpersonal environment, as well as the circumstances in which drug administration occurs, including the larger social, cultural, and political environments. So when we're thinking about what would be like a social political environment that could affect somebody's psychedelic experience, let me give you an example. So historians found that social policy can have a profound impact on the conditions of set and setting at a collective level. So looking back, sociology studies credit the rate of quote unquote bad LSD trips in the 60s because of increased police enforcement and harassment, as well as later refuted media-driven claims of LSD destroying the brain and causing irreversible chromosomal damage. Whereas in the 70s, there was a lessening of this political controversy and lessening of this moral panic surrounding LSD. And those were the reasons, partly, that credited a reduction in these psychedelic-related harms and improved the idea of set and setting for folks. So we can see that psychedelic assisted therapy proposes a distinct model of care that challenges the way mental health treatment is currently provided in healthcare. So PAT often involves a few doses of high dose medicine, which is quite different from a daily prescription that requires medications once or twice daily. It can involve quite a bit of time before and afterwards, both in terms of the med administration day. We saw that even a psilocybin session of 4 to 6 hours is quite lengthy. compared to what we might see in a normal healthcare provider meeting, even longer for LSD, up to 12 hours. And the prep and integration sessions can also be costly, both in time and resources, especially as we're getting into approaching healthcare with regulated professionals. So in the past, historians have argued that kind of the laboriousness and cost of PAT were among reasons why this therapy just couldn't compete with the emerging paradigms in the 50s, which included outpatient services and those daily self-admin medications. So now we're looking at developing contemporary, scalable PAT practices and policies that prioritize safe, skilled, ethically informed, and accessible care. And this is incidentally where a lot of my research is focused on. So moving on now into our third and final section, this is implications for healthcare. So we're going to be looking at where are we now, looking to the future. So keep an eye out for that slide. And we're going to end on a really short video that I think kind of encapsulates a lot of what I'm talking about. So where are we now? First, psychedelic clinics are up and running in certain cities and provinces, mostly using ketamine off-label, as well as psilocybin and MDMA through those special access programs accessibility. So Canadian providers are currently accessing psilocybin and MDMA either through clinical trials and often through the SAP program. Psychedelics acquired through the SAP and Section 56 are not bound to standardized practices, which means psychedelic practice has and is currently being delivered through various settings and models. There are also budding training opportunities around Canada. So when I just said that there's no standardized practices, there are groups that are trying to figure out what are the best ways to educate folks and how are we going to best prepare our healthcare providers for this as it's approaching mainstream healthcare. So most of where these education programs are coming out of are nonprofits, and this is including a number that are in different provinces and a number that also deliver their care kind of across, or their education across Canada. There's also a great Psychedelic Assisted Therapy graduate certificate program that was launched 2 years ago at Vancouver Island University. It's a year long and accepts folks with a number of different backgrounds as long as they have some kind of relatedness to psychedelic practice already. But again, at present, there's no official standardization for training certificates or training programs. It's just these opportunities are growing. And there are ways of engagement in the psychedelic space, including members of the public, healthcare providers, and patients. So I volunteer with the Psychedelic Association of Canada, and they offer a lot of lectures, a lot of learning opportunities and resources for folks kind of all backgrounds, including the general population, and then into healthcare providers and underground therapists. And then, of course, there are different kind of local cafes and communities that are popping up as well. So I wanted to talk a little bit about one province in particular that has put out regulations. So we're getting a little bit more now into what are we actually going to do and how are we going to practice as a province. So before we get into these regulations, I just want to clarify, Health Canada decides what drugs get to be used. The provinces decide how we use them. So in October of 2022, Alberta's government introduced a new requirement for psychedelic assisted therapy through an amendment to the Mental Health Services Protection Regulation Act that we have here. So these requirements came into effect January 16 of last year, and they apply to PAT used to treat a psychiatric disorder. So they don't apply to clinical trials, and they are not applying to folks with existential distress specifically. But I want to give you a little bit of an explanation of what these regulations look like. They're the first in Canada to come out, and as far as I know, the only province to put out regulations, though I imagine there are conversations going on elsewhere. So for Alberta specifically, to obtain a prescription, a patient must first visit a psychiatrist or a physician in consultation with a psychiatrist. This is different than how a lot of prescribers have been accessing the SAP program, and I'll get into that in just a minute. The second component is that the treatment must be administered in a facility that is overseen by a psychiatrist as a chief medical officer. And finally, treatment must be provided by members of specified health colleges. So the treatment itself has to be by a healthcare provider that either belongs to a college like the physicians and surgeons, registered nurses, psychiatric nurses, psychologists, social workers, or occupational therapists. So having these regulations put into place is a step forward for PAT. At the same time, there are a number of questions, particularly around accessibility. So the rule of that the psychiatrist or physician under oversight of a psychiatrist is restricting who can prescribe. So we know that there is a shortage of psychiatrists right now, and this also excludes the ability of nurse practitioners to be involved in any kind of prescribing. Secondly, there's a second question around the required training and education for providers. So I was mentioning that a little bit ago, that there is no standardization, and it's kind of that same question has persisted in these regulations. So it states in the document that while ensuring staff meet qualifications and training requirements, that is listed in the regulation, but there's no indication of what that means or where to go for training. There's also a pretty strong held idea in the field of psychedelic therapy that folks who deliver and provide this therapy should go through it themselves. And this is called experiential training. This is to have an idea of what it's like to go through this experience, as well as potentially have the opportunity to work through your own kind of work as a therapist. This idea of going through therapy yourself before providing it to somebody else is not a new concept. But the idea that a provider might have experiential training with psychedelics can sometimes be a little bit unpalatable for regulators. So there's questions around what kind of training actually does need to happen, and what does this look like for things like auditing when it comes to clinics. So all this to say, the Alberta regulations are stringent. However, there may be room for evolution that could increase accessibility, and everyone, including lawmakers, policymakers, and regulators, is all learning together. So even a tiny step forward is a step forward. So looking to the future with that giant eyeball, most of the research to date happens in randomized controlled trial environments. So as I mentioned before, RCTs, clinical trials, are the ideal way from the federal government to access psilocybin and other psychedelics. But as we discussed earlier, non-drug factors, including set and setting, are crucial to the quality of somebody's peak psychedelic experience, and predictive of their clinical outcomes. But controlled trials and clinical trials are a great way of getting information around safety and efficacy, but they specifically control for these non-drug factors. So as we progress forward, we will likely to start seeing trials for conditions or psychedelics that we haven't yet. So for example, because psychedelics are thought to promote this connectivity and neuroplasticity in the brain, were potential avenues for investigation that could come up in the future for clinical trials are things like using psychedelics to treat neurodegenerative diseases, including traumatic brain injuries or mild traumatic brain injuries, meaning concussions and post-concussive syndromes. And there's also, I think, the potential that we could be seeing microdosing kind of coming up on the map as well. And so microdosing just entails a smaller subsensory dose of a psychedelic over a scheduled amount of time. As I mentioned, though, this being said, because clinical trials inherently try to control and neutralize the setting, we are missing some key pieces around the influences of set and setting. So in addition to trial-focused research, we're seeing more clinical-driven and contextual research that captures the elements of those key components of set and setting. So we're looking at how these trial results actually translate into practice, including among various populations and marginalized communities, and then in various settings that just aren't able to be replicated in a trial. And finally, there are folks looking at how to best integrate PAT into mainstream healthcare. So this includes policy development and knowledge translation, and ultimately a main concern being accessibility. So with this treatment, there is a concern of the inverse law of care, meaning those who need the treatment the most face the highest barriers in accessing them. So for example, relating to stigma, this therapy really has like a three-pronged stigma, because there's stigma within healthcare and research fields, stigma associated with the substances themselves, and stigma of the conditions they aim to treat, which are mental illness and mental health concerns. So accessibility also includes streamlining application processes, reducing strain, and having timely treatment. There's one person, Janice Hughes in particular, who had gone through Section 56. Her last application was denied for end-of-life distress, and she was recommended by the government to go through a clinical trial just for her. So an N of one, a clinical trial for one participant. Anyone who's familiar with clinical trials, as I mentioned a bit earlier, they're very expensive and very time consuming. So this accessibility and streamlining application processes and access to psychedelics is paramount right now. We're also looking for the future of healthcare legislation changes, again, increasing education, awareness, and mentorship among providers, and creating these standardized guidelines and work towards destigmatization. So this is the little video I said we were going to end on, and then I'll stop talking.
I know the cancer's still there, but doesn't feel as helpless. I know that there isn't necessarily things that I can do about it, but it doesn't feel like as much of a helpless, hopeless thing. Having cancer feels like being dragged behind a horse. It's out of your control. Maybe this would be a little closer to riding the horse, as opposed to being dragged by it. We're still on the horse. We're still going places, but it's not as out of control.
So Therasil is one of those nonprofits that is doing both education for prescribers and providers, as well as helping folks access psilocybin and now MDMA through the Special Access Program. So this is one, Thomas Farrell's one folk they worked closely with. Oops. Okay, and that's the and in my presentation. So I have a ton of references here that I'm happy to send out afterwards if anybody is interested. And I'll stop.
Trisha, am I good to talk now?
Yeah.
Thank you. Thanks so much, Michelle. It's for that fantastic talk, and I'm sorry, folks, for joining later. And also, Patricia and I haven't figured out, but I'm channeling Patricia today. So apparently, I'm her. Whatever is happening with our Zoom accounts, we've crossed sections. So thanks everybody for being here, and just want to open up now possibility for some questions for Michelle. As you can see, Michelle is incredibly knowledgeable and experienced in many aspects of this work. And yeah, so we have a question in our chat. Feel free to either raise your hand or put it in the chat. So I'm going to read Karen's question first, if that's okay. And I realize I don't know everybody who's online, and I had to join late coming from another meeting. I am Vicky Bungie, and I am the director here at the Capacity Research Unit, and also get to work with Michelle on her supervisory committee and the amazing doctoral work that she's doing. So welcome, everybody. So Karen says, wonderful presentation and great work. I'm curious, what are key differences between the various treatments? Done some very powerful MDMA journey for trauma and have been wondering about trying psilocybin in the future.
Yeah, that's a great question, Karen. And it's one thing that I actually did want to touch on and I didn't. So when we talk about the classic psychedelics like psilocybin, LSD, DMT, those all share a very similar kind of non-ordinary state of consciousness because they act and activate that serotonin 5-HT2A receptor. MDMA is quite different, and that's why one of the reasons why it's considered an atypical psychedelic. Even ketamine, some of that feeling and non-ordinary state is a little bit closer to the classics, but MDMA, because it's working as a serotonin release and it also works on dopamine, the way that it's experienced is different, as you may know. One great thing that we're looking at for MDMA specifically is PTSD. And one difference between MDMA and the classics is that a lot of the therapy, the medicine day type therapy, is not necessarily as inward focusing as you would see with the classic psychedelics. So some of the actual treatment that happens is a lot more somatic with MDMA, and you might get a bit more of that kind of guidance and therapy in the actual medicine day session. So I read it that it was likened, MDMA is likened to using a microscope to looking at something. So it's the tool that's used to kind of push away other things to look down at the trauma, at the concern, at the issue at hand. Whereas psilocybin and kind of the classics is more of an inward experience. MDMA, a lot of it results in reducing fear, expectation, anxieties. And so in a way, it kind of wipes those emotions away. So somebody is able to look at an issue or concern with quote unquote a bit more clarity and without this cloudiness of things like guilt, anger, anxiety coming up. So the therapy of that looks a little bit different. And when I say it's a bit more somatic, which you may know about, and with things like PTSD, sometimes folks, it's a bit more of a body movement type medicine. So during the actual session, people might get up and walk around, they might pace, they might use pillows to kind of squeeze and have that somatic component to really kind of have that release and examine what's going on. Whereas with psilocybin or the classics, it's a little bit more of that inward. And so folks want to kind of come out and talk about what's going on, a lot of times they will be redirected inwards to look at it and have these insights and kind of go through it in a different way. I hope that answers a bit of your question. Does it, Karen? Does that answer?
Yeah, she wrote that tracks for sure.
Okay.
We have another question that from Afrat. Thank you for this knowledgeable talk, Michelle, specifically the practical aspects of how to approach research and gain more knowledge on the subject. Could you please share a little more about your PhD and who is your supervisor?
I would love to talk about that. So Vicky is my supervisor. And it's the best. I also have like an incredible team, a committee team. But what I really want to look at is a bit more of that clinical or that context-based research. So when I was talking earlier about there's that kind of clinical, really focused, the clinical trial focused research, it's really looking at safety, efficacy of drugs. What are these safe and efficacious for these kinds of conditions? Let's apply these models and see how they work. I want to look more at what's happening in actual real world practice, because as we know, there can be an enormous divide between the clinical trial world and the real world practice. And a lot of the regulations that get made are sometimes mostly based on clinical trial information. So I want to look at how is PAT experienced from the provider side and from the patient side, and what needs to happen for somebody to have a really excellent psychedelic trip and experience overarchingly. So I'm not planning to apply a specific therapeutic model or a therapeutic lens and say, through CBT, what needs to happen. I want to look at some of the bigger overarching questions. Like, we know that set and setting are important, but it wasn't until a little bit later that we found out, the social and political setting also has impact. So I want to look at in Canada, as we're going through this right now with these incredible legislation or regulation changes, this uptake of research, how is it actually being practiced? And what are kind of these influencing factors that could enhance or decrease somebody's experience? Yeah, that's what I'm looking at.
Great, thank you. We have two more questions. I think we have time for both. Leah, I'll read yours out, and then Shaheen, I'll come to you if that's okay. Leah's question is, what are the current barriers to having patients experience a home medicine day? I would imagine that giving patients the opportunity to experience this in a more familiar environment would be more conducive to a positive experience.
Yeah, that's such a good point, Leah. It is. Experiencing it in your own home is ideal. And so we've seen this with folks who got the exemptions through the Section 56s initially in 2020. To clarify a little bit about that specific exemption, when a patient is given that exemption from Health Canada, that means they are allowed to have their paper saying, yes, I'm allowed to purchase psilocybin. They can go to a dispensary, pick it up, and then there is no interaction with anybody else that's needed. So they may or may not access a therapist or a guide. A number of folks who did get that exemption did have some kind of guide with them, but a lot, like I imagine most, if not all, of the folks who got a Section 56 did it probably in their own home or in some kind of home or environment that they were really familiar with. Some of the SAPs now are also a little bit geared towards that way. There are some regulations that are saying for prescribers, the medicine that you hold on to now has to be in a safe locked box. There's some regulations for the prescribers. There's still some flexibility though to have it in a more comfortable area. But as we go from the SAP to clinical trial, all of those are getting more and more clinical focused. And what we see now with the Alberta regulations is that it has to be the wording is a little tricky to interpret, but it looks like it needs to be in a clinic type facility. Again, it's not clear what that means. It's not clear if that could mean somebody's home that they also do therapy out of, because that is a very legitimate way that therapy does happen currently. But I think what we'll see specifically with Alberta regulations, and I imagine the ripple effects of what those are into other provinces, is having them in defined clinical settings. So in a way, I think it's somewhat a barrier, I would say, is somewhat the regulation focused, not necessarily that care doesn't already happen in people's homes, because it does. It does with therapy, it does with home care, it does in many areas. But I think because there's a lot of a big eye on what's going on right now, and that in Alberta everything has to be audited, it kind of elevates things to a much more of a regulated setting.
All right, I know we're sort of out of time, but it's one, but Shaheen, please go ahead. Michelle, are you okay for one more question, and then we can wrap up? Thank you.
Thank you. Thanks, Vicky. Yeah, and we can even chat offline as well after this, but fantastic. I loved your presentation. I love how you are paving new pathways within nursing as well, within this area of research. I loved how you talked about stigma and just the various forms of stigma that's attached to PAT. I'm also wondering sort of this angle of cultural and racial stigma, and just how that affects equitable access to PAT, and if anything like that has come up for you within your work so far. And I know we're at 101, so we probably don't have a lot of time to have conversation about that, but maybe we can even chat later about it.
Yeah, that is a big thing that's come up. And there's a lot of questions of, how do we use these substances in different areas? They're called different things because we have different understandings of what they are, right? Like plant medicine, a drug, a substance. They come from different areas. And I think there's a lot of concern that the way psychedelics are being used, there's a lot of concern around appropriation, and how do we address this, and how do we use these in a certain way that is uplifting all boats, I guess. There is research also being done into how psychedelics can help racialize racial trauma specifically. So when we're talking about different kinds of trauma, racial trauma is one of them. But there's a lot of talk around how we approach PAT specific with cultural humility. And so a lot of PAT right now is a very westernized approach. So at the beginning, when I was saying it kind of, Western researchers were introduced to it in the 70s or in the 40s to 70s. That was very much the case. And now it's taken on a very Western biomedical focus. And we're seeing that even with the way we approach models. So we're using kind of these therapy models that are very individualistic. They're very cognitive behavioral based. And I think we're going to see that therapists are going to run into some big challenges with this when we're encountering a lot of different things. Like if we're saying that psychedelics are good for all of these kinds of things, we're going to be encountering events and things and emotions and histories that come up that Western approaches are not good with and are not ready to handle. So I think there is a really big focus in some areas on the cultural humility aspect, including trauma-informed approaches. That being said, a lot of the clinical trials, because of the way that that system is designed, is not great at that. And so I think that's a big reason why there's a lot of focus from researchers who are actually quote unquote in the field to look at it from a different lens and to get research out there that is not just clinical trial, so we can show that there's other angles to this that are as important as safety and efficacy.
Great. Thank you. Thanks, Michelle. so that brings us to our time. And Shaheen, thank you as well for doing the introductions. But I think lots of folks have lots of interest, and Michelle, you've just done an amazing job of grounding many of us. So this is new and different, and just to see the complexity of what's happening on the ground. So on behalf of all of us, just thank you so much for taking the time to share your knowledge and wisdom and curiosity with everybody. And thanks to everybody who participated today, and for the great questions and the great discussion. And this recording will be available, will be linked into the Capacity website. And and you can feel free to reach out, and we can connect you with Michelle if you have more questions and that kind of thing anytime. So yes, thank you, everybody. Enjoy the rest of your day. And we hope to see you again soon.
Thank you.